Hello, everybody. Thank you all for coming and for having me here to talk to you a little bit about what we know about social networks and health behaviors among Latinos. Today I'll be focusing on a few behavioral risk factors for chronic disease. But I wanted to first start by giving you a little bit of background on my education and training, because I think it provides you some insight into how I got to be interested on what I'm presenting on today. I'm currently at UC San Diego, and I actually just recently got promoted from postdoc to faculty, so that's fairly recent. My education actually initially started in East Los Angeles. How many of you guys are familiar with East Los Angeles? Okay, wow, a couple, great. So as many of you guys know, or for those of you guys who don't know, East Los Angeles is a part of Los Angeles that's predominantly Mexican American. It's a working class community. And so I was lucky that in high school I had some really good teachers and counselors who really encouraged me to move away and go to college. And so I was actually the first in my family to go to college, so I really didn't know what I was getting myself into. But I had a really good experience at UC Davis. I participated in several undergraduate research programs that really just changed the trajectory of my thinking and really my life. And so one of those programs was the McNair Scholars Program. Are any of you guys familiar with that program? Okay, good. Yeah, so what it does is it focuses on first-generation college students or minority college students, and it supports them, encourages them to go on to pursue a graduate degree, a PhD. And so it was through that experience that I really learned about other programs in terms of getting involved in research. And so I was encouraged by the McNair Scholars Program to participate in other programs. And one of those other programs was at Harvard. I did 10 weeks of research at the Harvard Medical School, and it was really the first time I had ever really been away from California and lived in the East Coast, and I really loved it. I think it was just a great experience, and if there are any undergraduates out there who are thinking of or considering not going to graduate school, I think this is a program that you should pursue or learn more about. And so it was that experience at Harvard that I got to meet a lot of really cool people, and they really encouraged me then to go on to pursue my PhD, specifically at an Ivy League school. And at that point, I really didn't know what an Ivy League school I just knew that it wasn't in California. But I applied, and I decided to go to Cornell, and I was in the program of physiology. And at that point, I really got to know what it meant to live in the East Coast, which is like freeze to death. It's really different from California, and I didn't know that before because of course I was isolated here in California, but I got to learn a whole level of isolation in upstate New York. I think I really had a tough time kind of connecting with people there and not feeling, like I belonged. So I think one of the ways I kind of coped with it was by, moonlighting as a community health worker while I was going to graduate school. And so that really helped me feel like purposeful and useful, made me feel good about myself. And so some of my responsibilities as a community health worker was to use my bilingual and bicultural skills. So I would go to migrant labor camps and do like health assessments, and then based on what I would find, I would go to the community clinics or healthcare providers in the community and connect the migrant farm workers and their families to the services in the community. And so it was a really good experience. It really did show me that I didn't want to be a lab scientist, that I wanted to learn more about health promotion. And I also wanted to learn more about how to teach individuals skills to change their behavior. The majority of patients I worked with had some sort of chronic disease. So they suffer from obesity, diabetes, and a number of other conditions. And so I was really frustrated with myself because my job was to educate and to help them basically manage their diseases. And I think I was awful at it. And I think it was because I wasn't trained. And so I really felt like I needed to go out and learn how to do this the right way. So I decided that I would pursue postdoc training in health behavior. I went to Brown and I did 3 years of postdoc training in behavioral medicine. I worked with Rena Wing, who is a leading expert in behavioral weight management interventions, and she was one of the principal investigators of the DPP program, which is the Diabetes Prevention Program. And it was another really good experience. I got a lot of good clinical training. I learned a lot, and I think one of the cool things about it is that they gave me a lot of freedom, and I got to do a lot of things that I really wanted to do, which is connect with community organizations. I would give workshops at the community, and I would really learn a lot from the participants in these workshops at these community organizations. And it gave me an opportunity to kind of do like a needs assessment. I developed this questionnaire where I would go out and assess whether what behaviors they were active in, and whether or not they were interested in weight management, and what components they were interested in. And I did this because when I got to Brown, there was kind of this hesitation to go out to the Latino community and develop programs for them, because they tended not to do well in the programs that they did develop for them, or they just would drop out. And so there was kind of this hesitation. So I really had to make a case for why we had to go out to the Latino community and really provide them some services. And so, to everybody's surprise, I got some really good, responses from this questionnaire, and I found that, women in particular, which were the majority of participants, they were really interested in participating in a weight management program, and they were, specific components that they preferred in this program. And so, one of the things that they indicated that they wanted in a program was to participate with another woman. And so I based an intervention based on those questionnaires. And so what we did is we developed a weight management program for Latino women, and we randomized. So we put them in two different groups, one of two different groups. So we put them in one where they came to a group-based intervention on their own, and we compared it to one where they came to a group-based intervention with a female partner. And so we conducted that study, and we really got some really good results compared to what's in the literature. And so, I was really excited, really bumped up my confidence that I could do this. And I thought I was ready to go to the next step, but I also learned that I still needed to learn more about, doing research in the Latino community. My training at Brown was excellent, but it was very clinical, and I needed the mentoring to kind of teach me how to go into the community and do research in a way where I thought was rigorous and at the same time respectful of the community. So after 3 years at Brown, I decided to do another postdoc at UC San Diego, and I was lucky enough to get a UC President's Postdoctoral Fellowship. And I was also lucky enough to get into another program that was funded by the Cancer Center at UC San Diego. And so what that allowed me to do was to pursue my MPH at San Diego State while I was working full-time as a postdoc. And so that was a really good thing, because it connected me with folks that really, really had tons of experience working with the Latino community. So I worked with John Alder and Suchi Ayala. And it also pointed me to a direction which, I kind of, was interested in, but it kind of really just solidified that I was really interested in studying social networks and health behaviors among Latinos, because in San Diego State, they have a CDC-funded site, the San Diego Prevention and Research Center, and they go out in the community every 2 years, and they conduct this big community survey. It's kind of like the mini NHANES, where they go out and they give them a battery of like the community, a battery of measurements, and they study their behaviors and their weight and their BMI. And so I was able to take advantage of some of their data and study social networks. And I think that really was the thing that showed me that, hey, I'm an interventionist, but I still, like to, do some cross-sectional study and evaluate, data. Secondary data analysis is one thing that I really enjoyed doing, because, it really it stimulates a lot of ideas. And so it was through that experience that I realized that I really wanted to pursue that area a little bit more. So I'll be telling you a little bit about what we learned based on that secondary data analysis. Okay. All right, so what I'll first do is I'll review what we know about behavioral risk factors for chronic disease, and I'll specifically focus on Latinos. Oops, sorry. I'll then discuss a little bit social networks and health behavior based on data that was collected from the STPRC, the San Diego Prevention Center. And I'll end by briefly describing two ongoing studies that I'm currently conducting at UC San Diego that are focused on understanding social networks and eating and exercise behaviors among Latinas. Okay. All right, so chronic diseases such as obesity, heart disease, cancer, and diabetes are among the most common but most preventable health conditions in the United States. According to national data and the CDC, there are 4 behavioral risk factors for chronic disease. They are excess alcohol consumption, insufficient physical activity, poor diet, and smoking. And so this figure here, what it includes is data from the National Health Interview Survey, where they estimated the prevalence of these behaviors among Americans. And as you can see, let me grab my pointer. And as you can see from these figures here, almost a quarter of the population are smokers and engage in what they call risky behavior. And more than half are physically inactive or are overweight and obese. And in this study, they used overweight status as a proxy for poor diet. We also know, as noted in this study, that the majority of Americans have one or more of these behavioral risk factors, so they tend to co-occur. So a person who is a smoker is more likely to be physically inactive and overweight. So this is concerning. When we look at the behavioral risk factor profiles among Latinos, we see that they're pretty different from non-Hispanic whites. For example, they're less likely to smoke, more likely to consume fast food, and fast food has been associated with higher energy intake, higher fat intake, and less fruit and vegetable consumption, and obesity status. They're less likely to consume the recommended amount of fruit and vegetable intake, so which is at least 5 servings a day. And they're less likely to meet the physical activity recommendation for leisure time physical activity. Currently, it's at least 150 minutes per week of moderate or moderate to vigorous physical activity. But they're less likely to consume alcohol. So this is further complicated by acculturation. And so acculturation, the adoption of mainstream attitudes and behaviors, has generally been associated with poor, or I should say, less healthy habits. So so acculturation can be measured by proxy variables, such as whether or not you're born in the U.S. or outside the U.S., the language you prefer to speak, English, in this case Spanish, or more years versus less years in the U.S. And so in general, they've associated acculturation with less healthy behaviors. So for example, a person who is higher acculturated or more acculturated would be more likely to smoke, consume fast food, less likely to eat the recommended amounts of fruits and vegetables, and more likely to consume alcohol, but more likely to engage in leisure time physical activity. So why should we be concerned about the health behaviors of Latinos? Well, as many of you guys know, Latinos are the largest ethnic minority group in the United States. They currently make up about 17% of the U.S. population. But their numbers are growing at a very fast rate, and in the next 50 years, their numbers are expected to double. So clearly there's a need to further understand social or interpersonal factors that may affect these health behaviors. So like health behaviors, social networks among Latinos are quite different. We find through several studies that Latinos have larger family-based networks. They tend to be locally bound, meaning their network members tend to live within the same neighborhoods. They're smaller in size, but they're tightly integrated, meaning there's frequent contact. And they tend to be less diverse, so they tend to be more homogeneous or similar in terms of gender and ethnicity. So while some of these network features or characteristics or attributes have been associated or studied in relation with health behaviors, the majority of the data has focused on non-Latino populations, so on predominantly non-Hispanic whites. So we still know very little in terms of behavioral risk factors among this population, their relation with social networks. So let's talk about what we do know based on literature based predominantly on non-Hispanic whites. So I first wanted to start with talking about the Christakis and Fowler paper that came out in 2007. I don't know how many of you guys remember, but there was a lot of media attention when this paper came out, and I think there was headlines like, obesity is contagious, obesity spreads among socially connected groups, and another one that I thought was really interesting was like, if you want to lose weight, lose your fat friends. And so those headings were based on data that was presented in this paper. And so what they did, Fowler and Christakis, was they analyzed data from the Framingham Heart Study. And the Framingham Heart Study is a longitudinal study that's been going on, I believe, since 1948 in Framingham, Massachusetts. So what they were able to do is look at a cohort, and they found that individuals who, an individual's chance or risk of becoming obese increased by about 57% if they had a friend who became obese, and they were able to kind of identify or isolate the sequence of events because it was a longitudinal study, and they had data from their social network members who also happened to be participants in the Framingham Heart Study. And so they visually depicted some of their findings by showing that here each yellow circle is someone who's obese. So as you can see, they show that yellow circles are surrounded by other yellow circles, meaning that obesity tended to cluster within social networks. Another study that gets commonly cited in the literature is a study coming out of Alameda County, and it was another longitudinal study. And this was a really interesting study because it started, I think, in 1965, and in a 9-year follow-up, they found that individuals who had low social integration or who had less social contacts, they were more likely to die from conditions such as heart disease and cancer compared to people who indicated that they had more contacts or were more socially integrated. So we know for quite a while this relationship between social networks and health. There's been a lot more data coming out showing the relationship between social networks and specific health behaviors. Some of it has come out from the Framingham Heart Study, but other ones are not longitudinal but cross-sectional. But some of the information is still very informative. And so I'll just go through a couple. For smoking, data from the Framingham Heart Study has indicated that smoking tends to cluster within social groups, but they have found that an individual's risk of smoking decreases significantly if they had someone in their social network quit smoking. And this was true for friends, siblings, and spouses, but to varying degrees. There was another paper by Cohen in the early 1990s, I believe, that showed that the diversity of one social network was an important predictor of smoking. So essentially, individuals who had less variety in their social relationships, so less diverse social networks, they were more likely to smoke. Diversity in social networks has also been associated with physical activity. So individuals with less diverse social networks are also more likely to be physically inactive. One thing that's consistent in the literature is that friends seem to play a role in the exercise behavior of friends. So individuals who have more friends in their social networks tend to be more physically active. The opposite association has been found with families. So individuals who are married, partnered, or have larger family size networks tend to be less physically active. And this is particularly true for women. In terms of diet, well, diet is very difficult to assess. So I think there's a lot less data on diet, the role, the relationship between social networks and diet. But there are a few studies, and one of them is the Framingham Heart Study. And so what they found is that there are similarities within socially connected people in terms of certain aspects of the diet. So, for example, snacks and alcohol consumption, not surprisingly, is similar among socially connected people. We also know through some cross-sectional studies that fast food consumption tends to be, frequency of fast food consumption tends to be very similar among friends, specifically young males. We know that married individuals are less likely to consume fast food than single individuals, and that people with larger families and more children living at home are more likely to consume fast food. In terms of alcohol consumption, so in general, I guess you could say family is discouraging of drinking and friendship networks are more encouraging of drinking, and that's been found consistently in the literature. So having a family in your social network, it decreases your chance of engaging in heavy drinking. We also know that married individuals tend to drink less than single individuals, and individuals who are parents and have children living at home are also less likely to engage in risky drinking. However, this is specific to women. And data from the Birmingham Heart Study found something really interesting, and that's that women are particularly influential in spreading alcohol behavior or alcohol consumption behavior. And what they did is they looked at the social networks, and they found that individuals who had a woman in their social network who either started drinking heavily or abstained from drinking, they were then more likely to go on and do the same. So it's not really clear why women are particularly influential in others' drinking behavior, only that it exists, and there's been a few ideas. But I think it's very complicated. We also know that women are, of course, are very different from men, but although women are less likely to drink than men, men tend to have more drinking friends in their social network, but women are more likely to indicate that their drinking friends are more important to them. So there are some gender differences. Sleep. I included sleep in here. It's one of those risk factors for chronic disease I think that we hear less about. Insufficient sleep has been associated with cardiovascular disease, diabetes, and obesity. So it is really important to understand, what are some of the factors associated with insufficient sleep, or even high-quality sleep. And so we know through the National Sleep Foundation that the recommendation is about 7 to 9 hours of sleep per night. We know that certain individuals get less sleep than others. Married individuals tend to report better sleep than single individuals. We know, interestingly enough, that friends tend to have similar sleep duration. So it seems to cluster within friendship networks. And the idea is, or the thinking is that, friends or cliques tend to engage in similar activities, so they might be on a similar type of schedule. And we know that friends are particularly important for women. So women with smaller social networks tend to report poorer sleep. And the last one is a routine medical checkup. That's a risk factor for chronic disease because it's important for early detection of a behavioral risk factor in a chronic disease, and delay of diagnosis can increase severity of the condition. So I think the majority of the research indicates that family is really important for influencing your health care seeking behaviors. Some of it has come from the Birmingham Heart Study. What they find is that individuals who had a spouse in the past year who had been screened for colorectal cancer were then more likely to go on and get screened themselves. And among women who had sisters who had been screened for breast cancer or had a mammography in the past year, that they were then more likely to go on and get screened for breast cancer as well. So some interesting findings there from the Birmingham Heart Study, and I think we'll be learning a lot more from that cohort in the next couple of years. So clearly we know that social networks are associated with our health behaviors in both positive and negative ways. But I think my goal when I got to San Diego, and specifically when I started attending meetings from the San Diego Prevention Research Center, was use what's been in the literature to kind of build and expand on it, to focus on Latinos, and to learn a little bit about more of this relationship between social networks and health behaviors. So my goal was basically to examine this relationship, and the San Diego Prevention Research Center is a CDC-funded site. It's a collaboration between UC San Diego State, and community-based organizations. And so it's the center is headed by Suchi Ayala and John Elder. And so I was lucky enough that, during the time where they were reviewing, their databases, one of the meetings they mentioned that the sociologist who had included the social network measure in the 2009 survey was no longer interested in participating in their group, so they didn't know what to do with this data. And so I just happened to be there, and I said, I have some idea of what I would like to look at. Can I potentially have access to this database? And they said, sure, of course. So it just really happened to be being at the right place at the right time. And so in 2009, they for the first time included a social network measure. And so about 400 Latinos in the community filled out this questionnaire. So it was a cross-sectional study. People in the southern part of San Diego are selected at random to complete this survey that they conduct every 2 years. So let's look at the measure. So they used what's called a name generator, and it's very similar to the one they used in the general social survey, which is a name generator type questionnaire where they asked individuals to list up to 5 people that they discussed important matters with. In this case, they asked to list up to 5 people whom they talked about personal issues or problems, and I'm thinking it's just the translation. It just fits better this way. And so we were able to look at a number of variables. The number of people they listed on this list, which is network size and composition, network composition, so the proportion of females, the proportion of Latinos, Spanish speaker friends, family members. And the last 3 variables, marital status and household composition, were part of a different questionnaire, the demographic, but nonetheless important structural features of networks that I was interested in looking into. So measures. So we looked at 5 behaviors. We looked at fast food consumption, physical activity, alcohol consumption, sleep, and a routine medical checkup. In 2009, they didn't collect any data on smoking. Apparently, they thought the prevalence was so low among this community that it really wasn't worth their time. They also didn't collect data on fruit and vegetable consumption. I think there's always a fear with diet that you're not going to ask the question appropriately and not going to capture the behavior, so they didn't ask it. So these are the behaviors that were available to me. And so I coded these behaviors to indicate health-promoting behavior, so not consuming fast food in the last week, engaging in the recommended amount of leisure time physical activity, abstaining from alcohol, meeting the recommendation for sleep, and having a routine medical checkup in the last year. Okay, so what did our sample look like? So the majority were women. The average age was about 43. Our sample majority had less than a high school education, were lower income. Majority were born outside the U.S., so predominantly Mexican origin, so in Mexico. Spoke predominantly Spanish, and they assessed acculturation by using the bidimensional acculturation scale. And so, according to that scale, the sample was largely lower acculturated. And compared to men, more women were lower income and were of low acculturation. Okay, so social networks by gender. So the average social network size based on the name generated questionnaire was about 3.5, and there was no differences between men and women. As you can see here, their networks were highly homogeneous in terms of ethnicity, and if you want to use Spanish language as an indicator of acculturation, you could say they were generally lower acculturated. Females made more than half of their social networks, although more women had more females in their social network than men. More than half consisted of family. And compared to men, women had more children living in the household. All right, so when we looked at the behaviors, you can see that less than half of our sample did not eat fast food in the past week or met the recommendation for physical activity. However, the majority did abstain from alcohol in the past month, had a routine medical checkup in the last year and met the recommendation for sleep. Compared to men, more women abstained from alcohol and fast food consumption. So for our multivariate model, so we then went on to look at our multivariate models, and we controlled for various variables. So we controlled for social demographic variables. They included age, income, education, acculturation, and in some case, health insurance status. Once we controlled for all those factors, a lot of our associations went away, particularly when, like for medical, when our dependent variable was a routine medical visit. Once we controlled for health insurance status, everything else went away. So that was a really strong predictor as to whether or not someone had a routine medical checkup. So you could have the most supportive, encouraging social network behind you, but if you don't have health insurance, chances are you're not going to get the care you should. Okay, so what's left over are some of the results that remain significant in our multivariate models. All right, so let's start with physical activity. So we found that with men with larger networks and more family members in their networks, they're more likely to engage in the recommended amount of physical activity. And so this is very interesting because usually family networks are associated with decreased likelihood of engaging in physical activity. And I thought this was interesting because these networks consisted mostly of adults. In fact, all of them consisted of adults. So I think this is something new, and I think it's potentially something I would be interested in pursuing because I was involved in 2 years in developing a pilot intervention for men in San Diego. It was a physical activity intervention, and some of the things that came up in the focus groups as well as the exit interviews was that family was a barrier for them to be physically active. And this is something you hear commonly among women, So I think the fact that we found some positive association, I think we should further explore. And I never really thought of developing an intervention for Latino men that included, adult family members, perhaps other men. But it kind of made sense. And so I'm not really sure, what other activities will come out of that, but I think it's just food for thought at this point because it's just not what you typically read in the literature. And okay, alcohol consumption. So we found women with larger networks were less likely to abstain from drinking in the last year, and this wasn't surprising because it's pretty consistent with what's in the literature with gender differences, social networks, and drinking behavior. I just want to say that our friendship network, so when we did the intercorrelation analysis among social network variables, we did find that friendship networks were more likely to be composed of females. So it's more likely that these friendship networks were specific to females. For sleep, among women, larger Spanish-speaking networks and living with more adults were more likely. Women who had larger Spanish-speaking networks and were living with more adults were more likely to sleep the recommended amount. I'm not really familiar that much with sleep literature, but one thing that does come up often in the literature with sleep is that they kind of think of sleep as some sort of mechanism by which social relationships affect health. So the fact that this association exists, communicating in Spanish with your social networks and having more adults in your social network, the first thing that came to my mind is that might be an indicator of some support that they might be receiving. We know that in general they say that among individuals or Latinos who live in neighborhoods that have high Spanish speaking and are immigrant neighborhoods, that they tend to be more socially integrated, and so that this might be an indication of some sort of support by just being in Southern San Diego is predominantly all Latino, I should say predominantly Latino and largely Spanish speaking. So it seems like this might be an indication of some sort of support that may may be receiving or reflect the composition of the neighborhood, but I don't know. Among men, those who were married, they were less likely to sleep the recommended amount. And I think this is interesting because another thing that does come up in the literature for sleep is that there is differences between men and women. So for some reason, women who are married tend to sleep better than their husbands, tend to sleep better than single individuals. And so it's been proposed that being in a partner relationship for women provides some sort of security. They maybe have access to more economic or social resources, and so that benefits their sleep more so than a single individual or perhaps their husbands, because their husbands might be the ones responsible for providing those resources. So that's what's come up in the literature, and I think that's a way of trying to explain why there's these gender differences in sleep and why specifically married women tend to sleep better than their husbands. However, in this study, we didn't find that married women slept better. So it's preliminary. All right, limitations. There were several. So an ecocentric approach, basically what that means is that we relied on individuals, the participants, to give us information about their social networks, and that is subject to human error. Cross-sectional design limits what conclusions we can make about causality. Small sample size from an epidemiological standpoint, that's very small. 400 is very small, and only 30% were men. Our sample was, again, very homogeneous. It was, southern San Diego, close to the border. And so there was very little variability in some of our social network characteristics and some of the health behaviors. So, I think that limited some of the analysis. Limited behaviors assessed. So, we didn't assess smoking or fruit and vegetable consumption or other behaviors just because they weren't assessed in 2009. So in summary, for men, being connected to more individuals and family members was associated with sufficient physical activity, but being married was related to not sleeping the recommended amount. For women, having more friendship ties was linked to non-alcohol abstinence and living with more adults, as well as having more Spanish-speaking members to discuss personal issues, were associated with sleeping sufficient hours. So this is pretty preliminary, but I think it's a good start, to stimulate some questions and like I said, I'm really interested in physical activity. So this kind of got me thinking, that maybe we should start thinking of interventions in a different way for men, and focus more on men. I think a lot of the physical activity research has focused on women and their families, specifically children. So I think I took away from this is a good start, and it definitely is building on literature that's out there, and predominantly non-Hispanic whites. All right, so I'm not sure how much time I have, but I wanted to take 5 minutes. Okay, great. The next few minutes in discussing some 2 studies that I'm currently conducting at UC San Diego, and they're the MIHA Study and a supplement study to Pasos hacia la Salud. So the MIHA Study, it's basically examining concordance in communication on rape-related attitudes and behavior among Mexican-American mothers and daughters. And I'm specifically interested in the intergenerational differences. So I'm recruiting mothers who are first generation in the U.S., so are immigrants to the U.S., and their daughters were born and raised in the United States. Although I've let a few in that were born in Tijuana, but came in at a really young age. They crossed over the border, although it's very complicated, because oftentimes across the border is not different than the other side of the border in terms of some cultural aspects. But so I recruited females, adults. They were overweight or obese and of Mexican origin. I recently got, in September, I got a small grant from Redes en Acción, which is an NCI-funded group out of Texas. And so what they're allowing me to do is expand the study to include mothers who are breast cancer survivors. So it'll be interesting to see how different they are from the diets that in which the mother aren't cancer survivors. But briefly, some of the things I have found was that there tends to be this role reversal with mother-daughter diets. So the daughters were born and raised here, so they're comfortable in English. They navigate the internet, and so they serve as advocates for their mothers who are immigrants and tend to be monolingual when it comes to their health. So the mothers majority have some sort of chronic disease, and so it's the daughters who go to the doctor, visits with them, who interpret for them, who describe their disease or their condition to their mothers, who explain their prescriptions, who go to the internet and find all this information and give to their mother. So there really is like a role reversal where it's the daughters who are now serving the parenting role for their mother. So it'd be really interesting to see if this applies to the breast cancer mothers, which I think will be really interesting to see, since some of the medical issues that they have to encounter are definitely really intense. Another thing that I've been finding is that mother-daughters who are more similar in their behaviors, so engage in physical activity and or make attempts at eating healthy, their communication tends to be more positive. So their communication is more open, there's more statements of empathy, encouragement, and support. And so we're hoping to use this information to develop a behavioral intervention that's going to be a weight management intervention for Mexican-American mothers and daughters, but it's going to have a strong communication component. And we're using some of their stories, because we interview them and we ask them to give us an example of conversations they had on topics of weight or eating or exercise, and we're using them as real-life examples in our intervention, in our curriculum, to provide real-life example of the dialogue. So when you teach them about communication, you have them role play, but they're going to be basically role playing an actual conversation that mother-daughters have had. And so I recently submitted a grant proposal to support the development and the implementation of this intervention. So I should know in a few minutes whether or not it gets funded. Cross your fingers. Send positive vibes. The last study is a supplement study. So I don't know how many of you guys know, but NCI provides some funding for early investigators through what they're called research supplements to support diversity and health-related research. So basically, you are attached to an R1 grant, and so you are not the main study, but basically a sub-study attached to a bigger study. And so there's the bigger study is Pasos hacia la Salud. And so basically what this intervention is, it's a internet-based physical activity intervention where women receive all their information through the internet. And so it's focused on Spanish-speaking Latinas. And so my sub-study is basically a study that's looking at their social networks of the participants in the study and their weight-related behaviors. So it's a mentored/training grant. So I'm basically working with a group of mentors. I'm working with Bess Marcus on physical activity, James Fowler on social network component, and Greg Norman on the scale development, since that's a new area for me. And so we're looking to see if certain sub-scales or items of this scale that we develop can predict physical activity outcomes in the study. So I'm giving this questionnaire/interview after a year, after they've been participating in this intervention for a year. So women start off as being underactive, so not meeting the recommendations for physical activity at baseline, so at the start of the study. And so a year later, they're very different. And so they're all adult women. And so one of the things I've been finding, and unfortunately I wasn't able to do this early on, was that women tend to comment that there's been changes in their social network. They started off a different person, a sedentary woman, and so now they're adopting all these healthy behaviors, and naturally their social networks, are going to look slightly different, if not a lot different, because you're a different person, and now you know, you may not be going out for lunch to the Cheesecake Factory every day with your coworkers, you know, going out for a walk. Now you're hanging around with Sally, who, you know, we never used to talk to before, but now you do because she's now your walking buddy. So those things come up a lot. So unfortunately, I wasn't able to capture those changes at baseline, but I think for a future study, I would love to capture those changes in an intervention and how that changes their social network. And I would also be interested in seeing if I could get the members of the social network that women list in the name generator come in and have them fill out a number of questionnaires as well. And I think that would be a cool validation study. All right, so that's essentially the end of my talk. I wanted to thank a couple people, the San Diego Prevention Research Center, my mentors, Suchayala and John Elder, who really supported me with my idea to look at the database and social networks and behavioral risk factors for chronic disease. And the two fellowships that supported my postdoc, that's the Cancer Center Partnership Fellowship, which supported my MPH, and the UC President's Postdoctoral Fellowship. That's it. Thank you. Any questions?
Do you want to field them? So we have about 15 minutes for questions. So do you come?
Yes. Yeah, I think I can.
Well, you mentioned on the sleep study that women that live with more other adults in the family are more likely to get the recommended sleep. Does it have anything to do with children? Maybe the fact that
I'm sorry. So women that what?
that have more adults living in the family have more likely to get the recommended sleep.
Oh, right.
Does it have anything to do with maybe children? The fact that maybe you don't have children, so they don't have.
Yeah, that is possible, but we didn't see women who had less children or more children. So women who had more children weren't sleeping less, and women who had less children weren't sleeping more. So it might be something about having. Well, we can't say, but we can guess that maybe by having more adults, they might be providing more resources or something on that line. But with children, yeah, that's very interesting that we didn't find that, because that is found in several studies with women and men. Yes?
Okay, I had two questions. The first question was really more of a curiosity comment, and that's that you're finding that the men are sleeping worse,
Yeah.
and therefore maybe benefiting a little bit less from marriage is really contrary to just about all other psychological literature, which suggests that men benefit more from marriage than women do.
Yeah.
So I thought that was really interesting.
Yeah, I know. I don't know what other explanation I have for that. I mean, yeah, I think most of the literature on sleep has really focused on women, however, because they're the ones who've been found to be different from men and single individuals. So there is some support for women sleeping better than men, but this one about men not meeting the recommendation, is slightly new. And again, on the flip side, women are apparently benefiting because of some sort of, security. Maybe we could say, well, it's the men who are working hard to provide the security.
Yeah.
And so for Latino men, this might be specific to them, I'm not sure. But, it's generally lower income immigrants, so they might be unique in that sense.
So the other question I had to do more with your sample characteristics, which is that you were measuring leisure time physical activity.
Yeah.
And I wondered if you were accounting for physical activity embedded within work, because especially for low income.
Right, that's a really good question.
Yeah.
So we use the Global Physical Activity Questionnaire, which measures different domains. So it separates leisure, occupational, transportation, and light physical activity. So this is specifically for leisure time physical activity. So it's completely separate from occupational.
Okay. Were the findings consistent though, or were these people who were actually getting quite a bit of physical activity in their workday, but were not getting physical activity in whatever leisure time they had.
Yeah, so you mean where there was an inverse relationship between, yeah, so I didn't actually look at physical activity of the different types and how they related to each other. I didn't.
Just curious, thanks.
It's a good question.